ಇವತ್ತಿಲ್ಲ, ಇವತ್ತು ಸ್ವಲ್ಪ ಕಾನ್ಫಿಡೆನ್ಸ್ ಹೊರಗೆ ಬಂದಿತ್ತು. ನಾಳೆ ಸೋಮವಾರ ಏನು ಅರ್ಜೆಂಟ್ ಇರಲಿ ಎಲ್ಲ ತೋರಿಸ್ಕೊಂಡ್ಬಿಡಿ.
The next is a plenary session. I think we're going to hear the exciting science about the advances in biomedical prevention by Dr. Kenneth Ngure from Kenya. Is Dr. Kenneth around?
Yes. It's an online lecture.
Yeah,
it's an online session.
Yeah, so we'll request the audiovisual.
Good morning. My name is Kenneth Ngure. University of Nairobi, Kenya, and I'm also affiliated with the University of Washington, and I'm the current president-elect of the International AIDS Society. This morning I'll be talking to you on advances in biomedical HIV prevention. I would have loved very much to be with you. Unfortunately, due to unavoidable circumstances, I'm not able to make it this time. So this is the outline of the presentation. I'll cover the introduction, I'll highlight the vaginal rings, injectables, and the next generation prevention products. I'll start by talking about why do we need HIV prevention? I'm sure many of us in the audience are asking, do we need HIV prevention in 2025? And just as a reminder, approximately 39 million people are currently living with HIV, and in 2023 alone, 630,000 people died from AIDS-related illnesses, and there were 1.3 million new infections. 1.3 million is a lot of people, like a population of a small country. And on the map on the left shows the distribution, showing that the majority of the new infections occur in Africa, and especially sub-Saharan Africa. So before we move to the advances, I want us to start with where we started from. And we started with oral PrEP, and we started with the hypothesis whether a pill a day could prevent HIV. And this was about 18 years ago. And this concept of pre-exposure prophylaxis is not new. It's used in malaria. PMTCT is a form of pre-exposure prophylaxis, so it's not a new concept. And what we learned from the multiple trials is that PrEP works, but only works when taken. As you can see with PrEP, if you only did one trial, we would have ended up throwing oral PrEP away, thinking that it worked. But what we learned from the multiple studies, including partners PrEP, which I was involved in, is that the better the adherence, the better the efficacy. But we also know that there are challenges with daily adherence. Not everybody is able to take a pill a day, even including the clinicians who prescribe and dispense these drugs. And this challenge of daily adherence is not only limited to the trials, it's also been seen in implementation studies. Like these studies cited here from a colleague of mine, Professor Jessica Harper from Harvard, was able to show that adherence wins with time. But we also need to remember, as we talk about adherence, is there are seasons of risk. Risk is not static, so people get in and out of risk. But the key thing is that there are people who struggle with adherence, and therefore different options for HIV pre-exposure prophylaxis would probably appeal to them. And that's why we are now talking about vaginal rings. And vaginal rings are important because they have also been used in the past for contraception. And the reasons why vaginal rings are important for prevention is because they are active, they have been shown to work for a month with sustained drug release. They are also easy to use, so women can insert the rings and move them themselves with little or no impact to sexual activity. They are cheap to make and distribute, and they are also demonstrate good safety profile. Remember that they act locally, so they minimize the systemic drug exposure, unlike the oral injectable products. They can also be inserted and moved in private, and they are adopted by women or their male partners. And as I said earlier, is that vaginal rings have been used to deliver contraception like the Luvaring, which has been extensively and Europe. And specifically, the piperine vaginal ring is a small flexible silicone ring containing 35 milligrams of NNR-piperine that delivers drug over a 1 month time frame, and it can be stored in temperature so no cold chain requirements. It's been approved by the European Medicines Authority and has also been approved by regulators in several sub-Saharan African countries. And though less efficacious than oral and injectable PrEP, it may be a good tool for those who are willing or unable to take the oral or injectable PrEP. The more recently, there was a study known as IPM 054 calculated that the 3-monthly piperine ring delivers higher drug compared to the monthly ring, and which could probably translate to higher efficacy. Here I also want to show a study that I was recently involved in, known as CHOICE or REACH study, that was looking at choice and adherence to the piperine and oral PrEP among young African women. And here we enrolled adolescent girls and young women aged 16 to 21, and they had an option of experiencing or randomized to experience the piperine ring and oral PrEP, and then they crossed over to the product that they were not using. And then they were given, now here's where the option comes in. After experiencing the 2 products for each for every 6 months, they were given an option to choose a product. And what we saw is that 2/3 of the women, 7%, chose the ring because of the reasons that I've highlighted earlier. And then that 1% chose oral PrEP. And this is quite important, showing that when you give options, people are able to choose a product that works for them. The other thing I want to highlight now is the recent study that had included 2 types of rings. It included the tenofovir rings and tenofovir levonorgestrel ring, or MPT rings. And data showed that these intravaginal rings were acceptable, safe, and validated by this small sample of Kenyan women. And the key thing when we did MPTs is in places like sub-Saharan Africa, adolescent girls and young women who are at the highest risk of HIV are also at high risk of unwanted pregnancy and at high risk of STIs. So products that do more than one purpose could probably appeal to this. And we also found that these rings were pharmacologically forgiving even for 3 days, but even when removed, they still give enough drug to protect for about 3 days. So this is a candidate ring to go to large phase 3 studies. So now we change gears a bit and move on to injectables for HIV prevention. I know there have been a lot of discussions about injectables for HIV prevention, and the first injectable was cabotegravir LA, and this is an integrase inhibitor, and the phase 3 trial, the first phase 3 trial was HPTN-084 that was a double-blind multinational study that was looking at intramuscular cabotegravir and compared to TDF-FTC, also known as Truvada, and it was in 20 sites in 7 countries in sub-Saharan Africa. And what this was able to show in the injectable, the Caberry arm, there are 4 infections, and in the oral PrEP arm, there are like 6 infections, translating to an 88% lower risk of HIV infections compared to those in the Truvada arm. And these findings were similar to what was also shown in HPTN-083, which had cisgender men and men who were cisgender and transgender women who have sex with men. And these two studies, the 2 products were very well correlated, but cabotegravir to oral PrEP, meaning that cabotegravir is a superior product, but an injectable, this injectable does not require daily adherence. remembering that cabotegravir is given every 2 months. So a product that does not require the adherent probably achieves better efficacy as demonstrated in this study. This leads to the recommendations by CAPRISA to be used for these populations, including co-injected and breastfeeding women, gender diverse population, and young people. And in this, it has been approved now by regulators in many countries, including in Kenya. However, both CAPRISA and the people in have faced challenges in implementation around some of it because of lack of product, delays in regulatory approval. Is that the lessons we have learned in implementing these products will inform future products, and especially the product that we are now going to talk about, which has caused a lot of excitement, which is the lenacapavir. And know Dr. Leila Mansouri yesterday shared about the lenacapavir, but this is one of the most exciting products for HIV prevention. I will do a recap. I'm not sure we'll be able to do as much justice. Lenacapavir is a long-acting potent inhibitor of the HIV capsid protein with in vitro activity against virus strains resistant to HIV classes. By targeting HIV capsid, lenacapavir interferes with multiple entry to late-stage processes of viral life cycle, and including capsid disassembly and nuclear transport, virus production, and capsid assembly. This, unlike CAPRISA, is a subcutaneous injection administered every 6 months and has an advantage over CAPRISA because of that longer duration. And being a subcutaneous injection, it amends itself to self-injection. Probably in the future, when people are more comfortable, they will be able to give themselves this injection. And this product was tested for HIV prevention in 2 studies, purpose 1. And remember that lenacapavir is being used in the US and in other places, including some places in Africa, for multi-drug-resistant HIV. And this is because of the multiple mechanisms of action. And in this study specifically, it was a 3-arm study that was looking at comparing lenacapavir with the FTC and FTC TDM. And for those who had the oral products, they had a placebo of the injectable. And for those who had the injectable lenacapavir had a placebo of either FTC or FTC TDM. Now let's come to the results. What this study demonstrated, which has caused a lot of excitement, is for adolescent girls and young women in the lenacapavir arm, there was 0 infection. Of course, this is a landmark finding. For those of us who have been involved in doing HIV prevention for the last 2 decades, this is the first time we have 0 infections. And this was done. And for those other arms, the FTC TAF arm and the FTC TDF arm had infections compared to the background HIV incidence. Similar results were shown on purpose 2, where lenacapavir reduced HIV infections by 96%, with 2 incident cases among the 2,179 participants, corresponding to close to 100% not acquiring HIV infection in the lenacapavir arm. And that's why the Science Journal or magazine voted for lenacapavir for prevention as the breakthrough of 2024. And I'm sure the audience agrees with me, based on those results, that this was a key breakthrough of 2024 and is a potential game changer for HIV prevention. And if it's implemented based on learnings that we learned with the CAP, and then if we don't fall into the same challenges, this could actually do quite well. And then moving on, we'll now move on to the pipeline. One of them is islatravir, and this is a first-in-class nucleoside reverse trace translocation inhibitor with multiple mechanisms of action, just like lenacapavir. And when you have multiple mechanisms of action, then you end up getting a product that is highly potent and is able to overcome, to have a high barrier for resistance. And one of the key things is that this makes it possible to use this product either as a monthly pill or long-acting implant. See, in November 2021, for the monthly pill, there was a decline in CD4 T cells, and this was not only in the prevention arm, but also for treatment. When islatravir used daily with the doravirine, there was also a decline in CD4 T cells. So, meaning that the product was halted, but that does not mean that there are no other products. I'm sure Mark is currently working on a product that should be going into trials later this year, which will again has a multiple mechanisms of action and which will probably not have the same effect in terms of CD4 cells, lowering the CD4 cells. Then the other mechanism, again, is more aspirational, but soon probably will go into trials. And this is the subdermal pellet system. And this could take the existing cabotegravir, which is 2 months, and move it to 6 to 12 months. And this would be through injecting these pellets, and which will not require removal. And the advantage of this is that we have the manufacturers inform us that if we increase the number of pellets, you are able to stretch the duration of use. So this is again one of the key developments that we should stay tuned in. And once you have this kind of technology, then you will be able to cabotegravir for longer duration, which could lower the cost and make it easier to scale. Then there are other mechanisms that I will not get into details much more, but one of them is one being developed by Organised, which is a non-degradable for delivering TAP. And this one is just this kind of format is you would then deliver TAP through this non-degradable implant system. And then there is also another refillable transdermal nanofluid implant developed by Houston Methodist Research Institute. There's subdermal pellet system by Conrad. There is a biodegradable reservoir TAP implants by RTI. There's non-degradable mini pump implants. There's non-degradable reservoir cap implants. So these are just showing that the field of HIV prevention is also looking at longer acting products. And this is again thinking about the field of contraception where we also have implant. And the more we provide choice, we are going to be able to have wider coverage for prevention. Similarly, you also have an MPT intrauterine system developed by Kenneth, and for this kind of system to deliver HIV prevention, what that tells us is that you need a very potent drug to be delivered through an MPT system. Then you also have depot systems, you have microarray window systems, you have a mini box, nano and micro particle-based delivery system, and electrospam nanofibers by University of Washington and others. In the interest of time, I will not get into these products, but they are going to the product, this company website, you'll be able to see these products. And in the future, we will be able to have very innovative HIV prevention tools. But then, when now we come to think about programmatic considerations for HIV prevention, as you are thinking about all these products, you need to think about cost. For example, the lenacapavir, which I've talked about, the current cost of lenacapavir is over $40,000 per dose. That would be a challenge in scaling up. But thankfully, Gilead, working with other companies, is working with about 6 generic companies to ensure that this product will be available and at a lower cost. And they are doing this even before lenacapavir is approved, because currently lenacapavir is being reviewed by FDA and other agencies like European Medicines Agency. So these discussions are happening so that once it gets regulatory approval, we'll be able to shorten that time from for production to ensure that it's widely available. The issue of funding is a real challenge because PEPFAR was pairing up with other donors to ensure that they would be able to get some of these products. But now with PEPFAR receiving less funding and on going to be a real challenge. It's actually focusing on treatment and prevention only for pregnant and breastfeeding. And what I would like to urge the audience is to continue advocating for refunding of PEPFAR because to bring prevention back to the table, and not for specific populations, but for all populations that need it. The other thing is I want to highlight is the issue of delivering choice. The more when you get product, we will need to train providers to be able to deliver choice in a way that people can be able to make informed choices and be able to switch from products based on their evolving needs. And then we also need to simplify delivery. From most of our research that we'll be doing, we hear people want demedicalized deliveries, and they want to get PrEP or in places where they live and work, so they can get it through pharmacies, through different ways. And then they also want to simplify delivery even within facilities. There is issue of testing. Again, this is a big issue that's being debated, especially when you come to injectable products. And because in the trials there was RNA testing, but difficult to scale up RNA testing. So those are some of the things. Then issues of the pharmacokinetic tail with injectable products. There is a challenge of pharmacokinetic tail. So for those who stop taking injectables because of this tail, then they will be need to be cancelled to use other products like oral products or drinks. So in summary, I want to highlight that the advances that have come for HIV prevention come to support the challenges that have been experienced with oral PrEP. And these advances are not only benefiting prevention, they are also benefiting treatment. And I know there was someone who gave a talk again earlier and today on long-acting treatment. And the reason why we are having all these choices is because people's preferences and needs are not the same. And we keep talking about the field of contraception. There's reason also to have options for prevention of HIV. And even when you have a highly effective product, there are still people who will not want to buy it. So you cannot say that you have a product that is highly efficacious, let's put all the others away and focus on one. Let's provide choice. So if you forget anything else I said today, remember that we are advocating for choice in both prevention and treatment so that people can take products that work best for them. And that the bar for developing the next generation of prevention and treatment product continues to rise. As you have seen, the whole pathway from oral PrEP to the ring to the injectables and different injectables is looking quite good. As I come to the end, I would want to thank all the participants that have participated in all the reference studies. I want to thank all the investigators, the institutions listed here, and the funders for who we could not do this study without their funding and their support. It takes many populations. If I had to have everybody involved in these studies, it would probably go to several slides. So I thank you, and if there are any questions, please feel free to email me, and then I'll be happy to engage and look forward to attending future meetings. Thank you.
So we would like to thank Dr. Kenneth for briefing us on this topic. And as we all know that in any disease, prevention is always better than cure. And in this particular disease, HIV, prevention is the only possible cure as of now. We also saw right from oral pills to injectables and the delivery modes also. And as he told that if there are any queries, we can always email him and take future his suggestions. So thanks a lot. With the permission of the co-chair, I'll like to end this session and move onwards towards the next session.